Now, this topic isn't in your, there's no special separate section on it, but there are still patients with this condition, and it's supposed to be on the chapter, but it's not. It was on the 14th edition. Anyway, so this hyperaldosteronism is exactly what it is. The patient has so high aldosterone levels. Now, the cause of this is usually a adrenal adenoma. Same adrenal adenoma that caused Cushing's disease the last time we talked about Cushing's. Now, this tumor, though, only secretes aldosterone. So what will happen to you if you have high levels of aldosterone? So your kidneys will reabsorb so much sodium and your fluid volume will be very high. So that means what's the primary problem in this patient? Severe hypertension. So similar to pheochromocytoma. Okay, so similar management. So what's the treatment? Okay, diuretics. Yeah, fluid restriction would apply. Can we give, because what will happen to this patient's potassium level?
It's going to be decreased.
It will decrease. So therefore, what diuretic will be given? Spironolactone. Okay. So if the patient is a surgical candidate, then we'll remove the adenoma, which again isn't any different from how we treated Cushing's disease with the adrenal adenoma. So same pre and post-op care. But if the patient is not a surgical candidate, then it'll be tons of blood pressure medications. Okay, diuretic therapy, beta blockers, because the heart rate here will be high also. Right, so calcium channel blockers will apply, ACE inhibitors. Yes. No, this is a different problem. Yeah, this is also, it's always possible. The name for this is also Conn syndrome, C-O-N-N. Conn syndrome is hyperaldosteronism. I've only seen one case in New York City in Woodhall, sometime 2016, 2017. Young guy, 35 years old. He was textbooks. If you open the textbook in front of him, he was exactly what the textbook says is going to look like. The patient was hypertensive. Patient's blood pressure was always over 200. It'll only go down. We give, let's say, hydralazine, which is a vasodilator. We give them hydralazine, 10 milligrams or sometimes 20 milligrams. It'll go down for a couple hours and then goes back up again. Sky high. Like I said, exactly what the textbook it was gonna look like. And that's all I can say about hyperaldosteronism. Are we clear? No questions? Okay. Just in case it comes up on the NCLEX.
You said Conn syndrome?